Good afternoon, everyone. Welcome to the Mount Sinai Medical Center lecture series. My name is Maria Narcis. I am market manager for Mount Sinai Medical Center. And this afternoon, I have the pleasure of introducing Dr. Oleg Gligich. He is a new physician at Mount Sinai, specializing in hematology oncology. I'm going to give you a little bit about his background. Dr. Gligich did his medical school training at Ross University, his residency at Jacobi Medical Center, and his fellowship at Albert Einstein College of Medicine. The doctor is also fluent in Russian, and he speaks a little bit of Spanish. He's very slightly fluent in Spanish as well. And we are very, very fortunate to have him at our Aventura campus practicing there. And he has appointments, same and next day appointments. With that, I'd like to turn it over to Dr. Gligich, who's going to give us a great presentation on cancer screening today. Thank you.
Thank you very much, Maria. That is a very beautiful presentation and a description. My name is Dr. Oleg Gligich. I'm a hematologist oncologist here at Mount Sinai Cancer Center, which means, in essence, I treat all hematological disorders and a large variety of cancer disorders, predominantly specializing in lung, breast, as well as bladder and prostate cancers, which are some of the cancers that we're going to briefly be talking about today. One of the reasons why I felt it's important to discuss cancer screening, as till this day, I still see patients in clinic that unfortunately get diagnosed with late stage cancers that could have potentially been avoided or prevented if detected earlier. Hence, I feel it's important to know what those cancers are and when to particularly focus on them. So I'm going to share my screen. Can you guys see this?
Yes.
Okay. So cancer screening. Well, why cancer screening? It's estimated that in the United States in 2021, almost 1.9 million new cancer will be diagnosed. 1.9 million new cancer cases will be diagnosed with more than 600,000 cancer-related deaths. So the cancer screening aims to detect cancer before symptoms appear with early detection and timely intervention. Makes sense. While targeting specific types of groups of populations based on age, environmental exposures, and family history. Screening frequently involves imaging, procedures, and blood tests, which we'll further get into today. Cancer screening is not completely harmless, and that's important to realize as well, as it can lead to either false negatives or false positive results and unnecessary stressors with invasive procedures that may not necessarily be needed. A screening test must be effective, safe, well tolerated, with acceptably low rates of false positive and false negative results. A little bit about cancer statistics. Well, in males, the most common types of cancers are prostate cancers, where in females, it's breast cancer. The most common types of cancers in both males and females, number 2 in place is lung cancer. Number 3 falls into colon. And looking at the estimated deaths amongst males and females is lung cancer, followed by prostate cancer in males, breast cancer in females, and colon cancer being in the 3rd place. And these are the cancers that we're going to predominantly focus on today. Hence, these are the top 3. Well, 4. Looking at the trends of age-adjusted cancer death over the last century, from 1930 to 2018, you can see pretty clearly that most cancer has not rapidly, but over the last 30 years has rapidly declined. It's important to note here that there's 2 types of cancers, including liver and pancreas, that have increased. And the concern here is because there's an increase of alcohol consumption. And the NCI recently published data that they're going to try to change the labeling for alcohol to reflect similar labeling as cigarette packaging, because alcohol increases the risk of not only liver cancers, but pancreatic cancers, colon cancers, and gastrics. It's very important for the community to know this because we are unfortunately seeing a trend in these types of cancers. So let's get into breast cancer screening. Breast cancer is the most frequent type of cancer amongst women worldwide and is the 2nd most frequent cause of cancer death in the United States. The average risk to develop breast cancer in a lifetime in a woman is 12%. That's 1 in 8. However, it's important to note that there's other factors that play a role as well. Family history, ancestry, such as Ashkenazi Jewish descent, associated with BRCA1 and BRCA2 mutations, mammographic breast densities, somebody who's had prior radiation exposure who unfortunately were treated for prior cancers, and things like estrogen use, age of menstruation, age of first live birth, number of pregnancies, and many others can also increase your risk of breast cancer. And these are important to discuss with your physicians. Screening mammography both reduces the odds of dying of breast cancer and facilitates the use of early treatments. So then who gets screened and what do we use? Well, there's many different types of government-sponsored groups and medical societies that recommend screening. They recommend frequency of screening being anywhere from 1 to 2 years, starting from 40 to 49, depending on individualized basis. But all of them will always recommend to start screening at 50, at least up to the age of 74. As medical oncologists, we frequently focus on the American College of Radiology and the National Comprehensive Cancer Network, which recommends frequency of screening to be on a yearly annual basis, starting at age 40 and going up to age 74, and then discussing whether continuation with your patients. So in summary, all women starting at age 50 should undergo mammograms regardless and should be performed at least 1 to 2 years apart. Women that are 40 to 49 years old should be evaluated on an individualized basis with shared decision-making with your physicians. As long as women are in good health and may be candidates for treatment at 74 years old, continued screening is recommended at that time. Screening modalities vary. However, we know that mammography is the preferred screening modality. It is the only imaging technique that has been shown to decrease breast cancer mortality. More recently, over the last few years, 3D mammograms, when compared to digital mammograms, have shown that 3D mammograms increase rates of cancer detection and have less false positive readings. It's important to know that ultrasounds are commonly used to clarify certain features of a potential lesion that was initially seen on a screening mammogram. In Mount Sinai, we use ultrasounds as an adjunct to our 3D mammograms during the same visit to decrease return rates as patients have other things to do. Screening MRIs are frequently not recommended for an average risk woman, however, are only reserved for high risk patients, such as the ones that have BRCA1 and BRCA2 mutations. It's important to also note that average risk women are not recommended to perform self-breast exams, as several studies have not shown any benefit and higher rates of unnecessary breast biopsies have been done. Moving on to prostate cancer, which is the #1 cancer diagnosed in men and the second leading cause of cancer-related deaths, almost 3,400 deaths annually. Prostate cancer mortality rates have declined in the United States between 1992 and 2017 by almost 20%. We've seen that in the graph shown prior. It's suggested that PSA blood screening could account for at least 45 to 70% of such decline, mainly by decreasing the incidence of distant stage disease. At the same time, prostate cancer varies in many men, grows slowly, and may not necessarily impact survival. Hence, routine screening amongst guidelines and physicians becomes controversial. Prostate cancer survival is related to many factors, especially the extent of tumor at the time of diagnosis. The 5-year survival among men with cancer localized to the prostate is 100%. However, compared to only 31% amongst those diagnosed with distant metastatic disease. So prostate cancer screening. Well, for prostate cancer screening to be valuable, it must reduce mortality and morbidity by detecting cancer at an early stage. However, detection at an early stage does not necessarily correlate with clinical benefit, as studies have shown conflicting results on reducing prostate cancer mortality. Increased detection of prostate cancer subjects patients to the risk of associated with prostate biopsies, anxiety, and treatment-related complications. These are all important to know, to realize whether one is or is not going to get prostate cancer screening. So then what's the approach? Well, patients and clinicians should engage in shared decision-making when discussing screening for prostate cancer. Screening may reduce the chances of dying from prostate cancer. However, most men who choose not to be screened with PSAs will not be diagnosed with prostate cancer. Makes sense, and will unfortunately pass from some other cause. although those men that decided not to be screened may die from prostate cancer within about a 3% lifetime risk in the United States. So then who's to screen? Well, the average risk man for screening for prostate cancer starts at age 50. It's done with a PSA-based blood test, which can be repeated every 1 to 2 years. And it's generally recommended to screen at least up to the age of 75. Men with higher risk who have BRCA positivity, and yes, men can also be BRCA positive, should be screened at age 40. African American men and men with first-degree relatives who have been diagnosed at age less than 65 should start screening at age 40. It's important to also know that the PSA test is not a specific test for cancer per se, and it may be abnormal in patients who don't have prostate cancer, who may have conditions such as BPH, which is benign prostatic hypertrophy, urinary tract infections, UTIs, or have underwent a digital rectal exam. However, PSAs can be followed over time in order to determine whether this is an acute elevation because of these conditions, or whether necessarily there's a chronic problem and they need to be further evaluated for prostate cancer. Men will be happy to note that digital rectal exams are generally not used as a screening test for prostate cancer here. So let's move on a little bit more to colorectal cancers, which is the third most common cause of men and women of cancer, as well as the third most common cause of cancer-related death. Patients diagnosed at an earlier localized stage have a much higher survival rate compared with those who have metastatic spread at the time of diagnosis, a very frequent recurrent theme in cancer screening. Most colorectal cancers arise from adenomatous colon polyps and take an average of at least 10 years to develop into cancer. So who needs to be screened? Well, the United States Preventive Task Force recommends to initiate screening at age 50, or at least they did before, as they recently drafted in 2020 October a proposal to start screening at age 45. Many clinicians, even prior to, have been screening African American men at age 45, as there's a higher risk of colorectal cancers among Black Americans. The American College of Gastroenterology in 2021 has changed their guidelines to initiate screening for all patients at age 45, regardless of race, and the American Cancer Society has followed suit. The recommendations are to screen at least to age 75 by mostly all guidelines. Choosing a screening test can be complicated, and shared decision-making when involving such screening tests would have many factors, as individual preference, risks, test effectiveness, safety, convenience, and cost. Non-invasive screening tests, such as the FIT and the multi-target stool DNA test, can be mailed directly to patients to be completed at the comfort of their own home. The ease of testing without bowel preparation, sedation, or invasive procedures is very appealing to certain patients. However, most physicians and expert screening guidelines recommend colonoscopies every 10 years for most patients at average risk. Well, why? Well, colonoscopies have the highest sensitivity of colorectal cancer and adenomatous polyp detection, and they allow for lesion removal anywhere in the colon during the procedure, and hence prevent cancer transformation at that time. To reiterate this on this graph, you can see that colonoscopies every 10 years can detect sensitivities of colon cancers up to 95% of the time, with other adenomatous polyps ranging anywhere from 75 to 95% of the time. However, stool tests, which is the FIT test, the FOBT, and the FIT DNA, can only detect colon cancers 73, 84, and 92% of the time. However, their adenomatous polyp detections are extremely low. And if these tests end up being positive, a patient would need to undergo a colonoscopy regardless. Hence, to reiterate, most guidelines and physicians recommend to obtain colonoscopies for screening almost every 10 years. Let's get into lung cancer screening a little bit. Lung cancer is the leading cause of cancer-related death among men and women. It's estimated that 1.6 million deaths worldwide will occur from lung cancer. As most lung cancer is attributed to smoking and environmental exposure, prevention rather than screening here is the most effective strategy. However, when prevention fails, screening allows for early cancer detection, allowing for more limited surgical resection and improved survival. Screening for lung cancer, and this is very important, has been recommended broadly by many expert panels since 2014. However, despite broad recommendations from almost all expert panels, lung cancer screening has been poorly adopted. It's estimated that approximately only 15% of eligible candidates have been screened. The question is, well, who to screen? Well, the United States Preventive Task Force recommends high-risk individuals, patients who are age 50, previously were 55. So anybody who's age 50 to 80, who has smoked 1 pack per year for 20 years, and are either currently smoking or have quit within the past 15 years. It's important that I indicated here that this was previously 30 pack years, and this was previously 55, so they've expanded their recommendations because patients are still not getting screened. Screening is done with annual low-dose CT scans, which means that the amount of radiation that you get from these CAT scans are at least 10 times less than the traditional CAT scans that you would get. It's important to also note that a regular chest radiograph and sputum is not recommended for screening. Unwanted consequences may occur during screening, like with all other screening tests, and this may include overdiagnosing of incidental benign nodules, needle biopsy and surgeries with associated morbidities and mortalities, anxiety, and radiation exposure. That being said, as we were able to see in the prior graphs, lung cancer has been going down, and it's important that we continue that trend for lung cancer to continue going down, and we need to continue screening for lung cancer in order to keep those numbers and that trend in the right direction. So last but not least, cervical cancer. In developed countries, there's been about 75% decrease in cervical cancer incidence and mortality over the last 50 years. And this is mostly related to the availability of screening and human papillomavirus vaccine programs. In the United States, there's only approximately 1,400 new cases of invasive cervical cancer and 4,300 cervical cancer-related deaths that occur each year. Makes it the 10th, less than the 10th most common cancer in the United States. However, in resource-limited countries, cervical cancer was the second most common cancer and the third most common cancer of cancer-related mortality. It's important to note, because unfortunately in research-limited countries, the availability of screening is not there. So screening for cervical cancer involves one of the oldest techniques called the Pap smear, which is developed in 1883 by George Nicholas Papanicolaou. And this was done in order to detect potentially precancerous cells, which are able to be seen here at the bottom of the slide, and now more recently using HPV testing as well. Screening for cervical cancer should be done on average risk patients ranging from age 21 to 25 with cervical cytology every 3 years. This is applicable to patients irrespective of whether they have or have not been have or have not had HPV vaccinations. So in essence, one of the things that I wanted to mention here is which cancers do not require screening currently. And it's important that I underline currently because in the future, this may potentially change. And cancers such as ovarian, uterine, gastric, pancreatic, bladder, kidney, head and neck, and skin do not have screening recommendations for the average risk population. However, what's the future of screening? Because currently only less than 20% of cancers that occur in the United States are detected via screening. It's anticipated, however, in the future that perhaps almost up to 50% of cancers can be detected by a liquid biopsy, and 25% of cancers can be detected by conventional methods like colonoscopies or mammograms. Liquid biopsies are blood-based tests that are able to detect circulating tumor DNA. Currently, they're being used to detect cancer recurrence in patients who have already been diagnosed and treated with cancer and have seen promising results in early detection. And I believe that this is probably the future of screening, as patients may be able to use blood-based testing as an adjunct to conventional screening in order to increase the rates of early detection, hopefully from this 20% to almost up to 75%. However, it's still unclear whether they may be able to substitute conventional screening altogether, but only time will tell going forward. These are my references, and I wanted to thank everybody for their time today. And if anybody has any questions, stick around and try to answer as much as I can.
Any questions for the doctor this afternoon? We'd be glad to take your questions.
I don't think we have any questions at this time.
Okay. Thank you all for participating this afternoon. As I mentioned earlier, at the start of this call, we have Dr. Gligich at the Aventura office, and we do take same and next day appointments, and we're there to serve you. Thank you very much.